We are live.
Good morning, everyone. I welcome you all to the fifth session of AIOS Guru Sangam. The topic for today is cornea. First, I would like to extend our sincere thanks to our esteemed organizers for pulling together this excellent academic session. Dr. Partha Biswas, President AIOS, Dr. Santosh Honavar, Honorary General Secretary AIOS, Dr. Manoj Chandra Mathur, Honorary Treasurer AIOS. It is my privilege to welcome our esteemed speakers for today. We have Dr. M. Vanati from RP Center, AIMS, New Delhi, Dr. Veena Pillai from Maharaja Institute of Medical Sciences, Viziz Nagaram. We have Dr. Devi Aishwarya Das from Dr. Agarwal Eye Hospital, Cuttack, and Dr. Bhavna Sharma ma'am from AIMS, Bhopal. Our expert panel for today includes Dr. Josephine Christie from Arvind Eye Hospital, Pondicherry, Dr. Kavya Chandran from LV Prasad Eye Hospital, Hyderabad, Dr. Manisha Acharya ma'am from Dr. Shroff Charity Eye Hospital, and Dr. Nikhil Gokhale from Gokhale Eye Institute. So we look forward for an insightful and interactive session for today. The topics for today include dry eye disease, corneal collagen cross-linking, decoding corneal edema, understanding its mechanisms and management, corneal dystrophies and degeneration. I'm Dr. Anu Malik. I have with me my co-moderator, Dr. Nandita Trivedi from Arvind Eye Hospital, Madurai. So without further wait, I would like to invite our first speaker for today, Dr. M. Vanati ma'am.
Thank you, Anu. I'll just move over to sharing my screen. Yeah. Am I visible and audible?
Yes, ma'am, you're visible.
Good morning, everyone, and nice to be with you on this Sunday morning to share with you a few insights on dry eye disease. This is not going to be an exhaustive talk, but it would probably cover all the salient features to enhance your understanding in this particular disease pathology here. I have no financial interest. So one needs to understand that the normal tearing depends on this neuronal feedback loop, and anything which is going to interfere with this is probably going to result in disruption of the tear film and subsequent disruption of the epithelial integrity of the ocular surface here. So that's the basic mechanism one needs to understand. And conventionally, we've always learned that the tear film comprises of lipid, aqueous, mucin, and this has got a little more sophisticated with addition of the glycocalyx layer and the epithelial cells, which closely integrate with the tear film here. So that's how the understanding of tear film has evolved here. And to enhance this, we also now need to understand that the ocular surface no longer comprises only of the epithelium of the cornea and the conjunctiva, but also comprises of the lid and the associated adnexa, involving the goblet cells, the glands, the meibomian glands, the glands of Moll, the glands of Krebs, the various subparts of the conjunctiva. So health of this entire unit is essential for the health of the tear film integrity, and anything which is going to disrupt with this is going to result in a dry eye disease. So that's how a healthy tear film, a diagrammatic representation of a healthy tear film looks like, with all its component layers assembled in order. And anything which leads to this disruption is going to interfere with the epithelial integrity and the subsequent health of the ocular surface here. So when you look at an ocular surface diseases which contribute to dry eye, these can be categorized as diseases of the conjunctiva, diseases involving the tear film per se, and diseases of the lid margin and limbal stem cell deficiency diseases. I think this is an overview of the categorization, and any form of conjunctivitis, be it allergic, be it infective, be it autoimmune, or be it other forms of conjunctival degenerations, are all going to result in tear film interruptions here. Dry eye disease per se, because of tear film interference, evaporative dry eye disease or an aqueous deficient dry eye disease is going to result in the dry eye disease, which we largely see in most of our patients here. Again, lid margin diseases like blepharokeratoconjunctivitis, meibomian gland diseases will also result in dry eye, and conditions which cause limbal stem cell deficiency like Stevens-Johnson's chronic chemical injury sequelae, ocular cicatricial pemphigoid, all these diseases can also cause a tear film disruption here. So it is important to understand that there are a variety or varied categories of the pathology are going to produce one symptom, that's the dry eye here. The definition of dry eye, which was recognized as a particular entity, started way back in 1999 as a disruption of the tear film with due to tear deficiency or excessive evaporation, which damages the interpalpable ocular surface and hence is associated with symptoms and signs of ocular discomfort here. The DEWS workshop, the dry eye workshop, later came on in 2007 and defined this as a multifactorial disease of the tears and the ocular surface. We've come a long way since then, and one has to understand that there is this vicious circle of ocular surface irritant pathology, which leads to an inflammation and which subsequently goes on to tear deficiency and instability, and this is a cycle per se to with itself. This is a picture which most of us would have seen in many textbooks and in many talks here. So you understand the multifactorial categorization or the multifactorial etiopathogenesis of dry eye disease here. So you could see there are so many confounding factors which can lead to a dry eye disease pathology here. But largely, we would classify it into an either aqueous deficient dry eye or an evaporative dry eye disease here. But what is advanced is that that the dry eye disease deficiency manifestation is not limited to just aqueous deficiency or evaporative, and now we do have a mixed category as well, where the percentage of each of these two categories can differ depending upon the patient's presentation and pathology. We also need to understand how to categorize or how to grade the severity of the dry eye level depending upon the discomfort, the visual symptoms, the conjunctival hyperemia, the staining due to epithelial disruption, epithelial cell disruptions here, the corneal signs and the meibomian gland signs, the tear film breakup, and the Schirmer score. So this can be categorized to level 1, 2, 3, or 4 depending upon the severity involving all these parameters of in a particular patient here. The treatment recommendations, which have also been given, ally closely with the severity grade here. So if we have a level 1 grade, it is recommended that you would treat the dry eye with probably lifestyle changes, or these patients might need tear supplements here. And you manage the associated pathologies which are present here. When there's a level 2 severity, you'd probably add on or increase the frequency of your tear lubrication with adding on anti-inflammatory agents as well. And the severity goes on higher to level 3. You're going to supplement with your biological topical therapies here. And the need for punctal plugs can be considered. And when it is a very severe dry eye disease is when you're going to contemplate using surgical intervention modality. So this is a rough guideline which sort of existed, but the later classifications or the later advances have probably refined it or enhanced it further here. So we need to understand the epidemiology, the pathogenesis, the history, symptoms, the various questionnaires which are involved in dry eye disease evaluations, the in-office diagnostic tests, the lid and ocular surface disorders which can cause these dry eye diseases, and management. So when one is probably looking at a dry eye disease, this is a whole gamut involving almost the entire pathology of several ocular surface diseases here, and understanding them is going to be imperative in learning to manage your dry eye successfully here. So I think 30 minutes is not probably going to be enough, but then I'm going to give you an overview of this here. Among the top questionnaires which one would want to adopt, the Ocular Surface Disease Index one is something which is frequently adopted, and the conventionally used one had about 12 questions, and which were graded according to their responses, and normal values were considered to be below 12, with mild dry eye deficiency in scores between 13 to 22, scores of 23 to 32 referring to moderate, and scores above 33 referring to severe dry eye disease. But the recent TFOS DEWS III has revised this, and I will be talking to you about it subsequently here. When we need to assess clinical tests for assessing the lacrimal function unit, we need to look at the tear secretion assessment, the tear volume assessment, the tear clearance assessments, evaluation for tear film stabilities, the lipid layer assessment, ocular surface damage assessment, and the tear protein assessment. So this is sort of a comprehensive list which we need to understand and master for assessing the integrity of the lacrimal functional unit in entity. So we'll go through them one by one. So the first and foremost, which commonly all of us use and perhaps is one of the least reliable among all the ocular surface evaluation tests, but something which is almost the one which is mentioned and almost performed always on in office, is the Schirmer's test with and without anesthesia. Is the one I think all of us know about its methodologies here. And in the interest of time, I'm not going to elaborate on these details here. The Schirmer's one is what we commonly perform, and when there is a wettability of the Schirmer strip, which is less than 5 millimeters in 5 minutes, then you know that the patient is having a dry eye disease or severe dry eye disease in the clinical assessment evaluation. Schirmer's 2 and Schirmer's 3 are not routinely performed. There is also a Jones basal tear secretion test here, but what is commonly performed in-house is the Schirmer's test 1 here. We also have other similar tests to evaluate the tear wettability values, and we have the phenol red thread test. Again, these are not very commonly done because of the availability of the phenol red threads is not as convenient as that of your Schirmer strips. So this is a simple red cotton thread impregnated with a pH indicator phenol red, and this is inserted into the lower conjunctival sac, placed in for 15 seconds, and the color turn from yellow to bright orange, and the length of the thread that gets wetted gives you the measure of the tear production, with the normal values of about 9 to 18 being expected, and anything less is going to be indicative of the dry eye disease here. Tear volume assessment tests here. So among tear volume assessments, these have come in recently, and these involve imaging of the tear film, and you could look at the tear film meniscus height, largely by using your anterior segment OCT, but your simple slit lamp evaluation of the height of the tear film at the lower lid margin. It can also help you to assess the health of the tear film meniscus in our patients here. A height of 0.1 to 0.3 is considered to be normal, and anything which is lesser than that is going to be indicative that the lacrimal lake is not healthy, and there is a deficiency in the aqueous secretion in these patients here. Yeah, there are various other devices, but these are not easily available. The strip meniscometry is another reliable evaluation, but I think you will need special strip meniscometry strips to assess these particular parameters. And these are how the imaging parameters will look at when you look at tear meniscus evaluations of your patients here. Tear clearance test, again, I think in a very busy in-office evaluations, we hardly resort to evaluation of tear clearance test, but among these you have the fluorescein clearance, the clearance test. And I would urge all the residents to go back and familiarize yourselves with all these tests when you need them for your examination evaluations and question answers. Yeah. What we rely upon most of the time is evaluation of the tear film stability, because that's going to directly influence the health of the epithelial cells and the corneal tear film staining them. So we have the invasive and the non-invasive tear breakup time in our patients here. And this talks about how well the tear film layers the ocular surface and how easily the tear film is liable to break up. And this gives you a very good evaluation aspect of the integrity of the tear film, the stability of the tear film here. We commonly use the fluorescent dye to stain the tear film here, and ask the patient to blink a couple of times, and then uh, uh, observe for breakup spots which appear as dark spots in a uniformly stained tear film. The time taken for the appearance for the first breakup spot is going to be taken as the tear breakup time. We'll repeat it about 3 times and take an average of these patients. And random appearance of the tear spots is important when you're evaluating. And take care if you have a pterygium or if you have a pellicula, you're going to have a consistent breakup, which could be earlier in that particular region. You have a non-invasive tear breakup time test where you need not invade the tear film by applying a dye, because that is also going to lead on or not give you an exact estimation, depend on the volume of the tear film stability assessment here. So you have a non-invasive tear breakup time. The Tearscope Plus by from Keeler's helps you when you look at this. The reflex of the Myers on the tear film and the time taken for disruption, a distortion of the Myers is going to give you a non-invasive PVUT. Many of your ocular surface analyzers now provide this estimation and give you non-invasive tear breakup time, and this is a more consistent and reliable method of measuring your tear breakup time. As we move on to lipid layer assessment, assessing the health of the lipid layer is important, and you do have mevometries to assess the tear lipid layer content by in form of the interference patterns of the lipids present on the tear film. Yeah? And again, this is more of not more of a day-to-day value, but if you do have your office suite dry eye assessment suite, then this is incorporated into most of the devices which are available commercially now. Looking at the tear film ocular surface assessment, you could look at ocular surface staining scores and the tear film osmolarity here. The tear osmolarity is now not considered a very reliable aspect and probably has a limited load in a particular subset of patients where you would want to assess the tear osmolarity, like those who are on chronic anti-glaucoma medications and those who are going to go in for with dry eye disease going in for cataract surgeries, you would probably look at their tear osmolarity levels before you would want to take them up for cataract surgery here. So by and large, this is now not considered as a very reliable method of looking at, but then you do have the tear lab, which gives you the in-office tear osmolarity assessment values here. Ocular surface staining scores, I think this is something which has the highest reliability in terms of the signs and symptoms evaluation or correlation with the signs and symptoms of the patient. A very simple in-office diagnostic test evaluation that helps you to assess the amount of damage to the conjunctival and the corneal epithelial cells. And we do have a variety of staining techniques, and this by itself is a class on itself to understand the various staining patterns here. We usually follow the National Eye Institute staining score methods for the cornea and the conjunctiva, where the cornea is divided into 5 layers, into 5 regions, as shown in this particular diagram. And the conjunctiva is divided into 6 regions involving the nasal and temporal conjunctiva, each being subdivided into 3 regions by themselves here. The staining score of 0 to 3 provided for these, and these help to give you the severity. The compounded scores help to give you the severity, a score of more than 3 when in corneal epithelial staining, and a score of more than 3 in conjunctival epithelial staining is going to be indicative of dry eye disease here in our patients here. There are older screening methods like the Oxford or the Van grading methods here. These can also help you, and these are older methods, and now we almost resort only to the NEI grading methodologies. So last but not the least, to evaluate the epithelial health of the epithelial cells, we also have the conjunctival, the corneal epithelial impression cytologies, where if you need to look at the presence or absence of goblet cells, depending upon whether you're looking at the conjunctiva or the cornea, which is going to tell you about the goblet cell health if you're looking at the conjunctiva. And if you find goblet cells on the cornea, you're going to evaluate them as the presence of liver stem cell deficiency here. So impression cytology is another method of evaluating the ocular surface damage dependent upon the disease levels commonly done for limbal stem cell deficiencies in our patients post chemical injuries, post Stephen Johnson's. Yeah. The level of severity of dry eye is something which I always would urge our residents to look at, whether it's mild, moderate, severe, level 1, 2, 3, or 4 here. And that would help you to correlate with the quantum of management modalities you need to resort to when you are adopting to these patients here. So these are simple clinical examples showing you the lackluster of the conjunctiva, the lack of the corneal lusters here, the presence of corneal epithelial staining and conjunctival epithelial staining. The conjunctival epithelial staining commonly tends to get missed by most of our residents. Use the green filter, and that gives you a wonderful estimation of looking at the conjunctival epithelial damages as well. Pictures such as these you would see in patients of chronic ocular surface dryness versus because of rheumatoid arthritis. You could see some amount of or a significant amount of lid disease as well associated in these patients. There's a higher tendency for infection with bacterial keratitis in these patients here. So the common things you would need to look at in management is alteration of environmental factors if there is an evaporative disease in these patients here. The high lid hygiene in cases where there is a disease pathology affecting the lids, which is contributing to the dry eye disease here. The aqueous deficiency being supplemented by giving tear lubricants in these patients. Resort to measures that will help to retain whatever tear is present on the ocular surface by using tear plugs and by dry eye punctal plugs and by dry eye goggles. And where the secretion itself is less, you would probably want to use tear stimulation by oral secretagogues in our patients here. You need to supplement tears besides tear lubricants with also biological tear substitutes, which have a higher quantum of growth factor, which would help heal the epithelial damage which has already been caused onto the surface here. Inflammation always coexists, or inflammation which is induced because of the tear film deficiency will need to be controlled by anti-inflammatory agents, and in very severe cases, you will need surgical intervention in form of salivary gland and duct transplantation. So this is how the flow of understanding the pathology, understanding the source of the dry eye disease helps you to decide on what is the quantum of management or the various categories of management which you need to put in or need to adopt for each of the patients here. So this was an older recommendation of tear deficiency disease and evaporative disease. It is a globe wheel, and it helps you what all you need. It helps to guide you on what all you need to look for and what are the tests you need to do, depending upon the disease pathology which causes the dry eye disease for the particular patient here. Most of us do fail to recognize the severity of the dry eye disease caused because of lid pathologies, meibomitis and meibomian gland dysfunction being top on the list here. So I would urge you all to learn to grade your meibomian gland dysfunctions, which also helps you to resort to have some form of several forms of advanced management modalities, which are in the recent advances for meibomian gland diseases. So these are some of the clinical grades of meibomian gland dysfunctions and meibomitis pathologies here, which need to be addressed when we are evaluating or treating our meibomian gland dysfunction. So treatment of meibomian gland diseases, treatment of the arthritis, treatment of associated demodex, which is now recognized as one of the factors or the leading cause for a chronic refractory blepharokeratoconjunctivitis, all can lead to dry eye disease, and those with frequent hordeolums on their margins of the lids and chalazions. These patients probably would go on for ocular rosacea, which is again a common reason for dry eye disease here. Ocular surface disease, as obvious as this, is usually not missed, and you have a variety. These are some of the clinical pictures, and I think knowing to grade and stage our ocular surface cicatricial pathologies will also help us to understand the the treatments we need to resort to in terms of autoimmune therapies for these patients, apart from topical therapies here. These are oculocicatricial pemphigoid, looking at the immunohistochemistry staining of the immunodeficits on the basement membrane zone is something again important, which we are looking at a diagnosis. But several times you would end up biopsying the skip zones, and this is perhaps not always not a convincing test to help you. The clinical signs and symptoms are more important in evaluating such patients. The step ladder treatment approach in managing the ocular surface cicatricial pemphigoid is important to understand, and you need to have a close integration with your medicine and rheumatologist person to help you manage these patients successfully here. Again, and the other disease entity is Stevens-Johnson's here. The acute Stevens-Johnson's, the erythema multiforme, toxic epidermal necrolysis are all disease variations depending upon the severity of the disease. And commonly, we land up managing acute and chronic Stevens-Johnson syndrome, which could be minor or major. So these pathologies is something which we need to understand. And when we are looking at chronic Stevens-Johnson's patients, it's not only the acute pathology, but the chronic disease itself could be mild or severe, associated with components of scleritis. And you have other defined disease presentations like an MMP, like ocular surface failures, and recurrence with exacerbations also need to be addressed. It all contribute to dry eye disease, which could be as severe as this, with acute epithelial breakdowns, with conjunctival epithelial damage, which needs to be managed with appropriately, but not just by lubricant anti-inflammatory therapy, but you would probably also need interventional methodologies like amniotic membrane grafts and mucous membrane grafts in our patients as well. So I think I'll quickly run through this. The surgical interventions could be superficial keratectomy, amniotic membrane transplantations, junctable autografts, limbal autografts, or allografts here, and bioengineered limbal stem cell transplants, which could be cultivated epithelial limbal stem cells, allogenic, or could be autologous. And of course, the last resort is keratoprosthesis and keratoplasty, being limited in those cases of very severe dry eye disease here. Just to touch upon and cover, to complete the cover on dry eye disease pathologies, we now have the TFOS DEWS III, and how it has moved or how it has refined our understanding on dry eye disease or its recommendation. Now it is defined as a multifactorial disease which affects or is characterized by the loss of tear films, ocular surface homeostasis, with a key mechanism centering on tear instability, the resultant hyperosmolality and the inflammation, which leads on to the ocular surface damage and the associated neurosensory dysfunctions. So these are all the components which you need to consider when you're evaluating the dry eye disease here. And it now moved on to a factor where you, instead of just considering the tear film, you're considering a tear film along with the entity of the ocular surface. So there's an expanded scope of management and disease pathology evaluation when you are looking at it. So that's how DEWS III, which is given in 2025, has moved from the earlier evaluations of DEWS I and DEWS II, or recommendations of DEWS I and DEWS II. The step one of DEWS III is to assess the symptoms, the impact of the assessment being graded using particular questionnaires, and the newer or OSDI questionnaire 6. The step 2 is looking at or quantifying the amount of damage done because of the various parameters of dry eye disease. And step 3 is the treatment modalities which you need to adopt based upon the phenotype or the source of the or the source that's causing the dry eye disease here. So we do have the OSDI 6. It gives you a cutoff of greater than 4 or more is now diagnosed as a dry eye disease, and this is now elaborated with only a 6 questions questionnaire. Reserve what we had 12 earlier, and this in combination of one of all of these two on the right side, either a non-invasive a tear breakup time, an altered osmolarity or staining score involving cornea conjunctiva, the lid margin staining of more than 2 millimeters in length or 25% in depth. So this is how these two has changed the diagnostic algorithms here. And it's nice to go back and update yourselves on the OSDI 6 here and the 6 parameters which now form the OSDI scoring here. So we have now moved on from a spectrum model of evaluation to a etiologic driver-driven model for adopting the management of dry eye disease as per the TFOS here. And you address the patients in terms of whether they are having a tear film deficiency, eyelid anomaly deficiencies, pathologies, ocular surface abnormalities, and other systemic system-driven etiologies such as autoimmune disorders. So once we need to learn to assess our patients along the lines of these etiology-driven spectrums here for evaluating and successfully managing our patients, so that our success rates in giving a comfortable ocular surface is better than what we used to adopt earlier on. And this is how the tear film assessment has now changed, where the glycocalyx and the corneal epithelial cell is also integrated into the tear film, and most of our commercial available marketing of drops is perhaps targeting these sophisticated microanatomy understanding of the tear film for dry eye disease. Yeah. So we need to look at even the blink rates, the the completeness of the lid closures, the presence or absence of anterior posterior blepharitis, the meibomian gland dysfunctions, all these being important, and you will tailor your treatment according to these as well. We do have mucin layer therapies, we have lipid layer therapies, apart from the routine tear film agents which are commonly used for these patients. So mucin layer therapies in form of ribapamide, diclofenac, RGTA, tebelaramide, these are all still not available commercially. We have lipid layer therapies, a variety of them here. We'll just touch upon these as I'm going to talk to you on the recent advances here. So this is a table which comprehensively helps you to understand how the pharmacological therapy, the various amounts of pharmacological therapy besides tear lubricants. We have mucolytic agents, we have oral muscarinic agents, we have topical systemic ointments, we have topical anti-inflammatories in terms of corticosteroids, which functions as immunosuppressants. We have other immunosuppressants, immunomodulators such as cyclosporin, tacrolimus, and interleukin-1 receptor antagonist anakinra. So these are all various formations which help us to decrease the inflammation here. Tear biological supplements in form of autologous serum and the various other combinations, which I'll just show you one particular slide, which will give you a comprehensive understanding of this. Environmental modifications, dietary modifications, eyewear devices here, surgical interventions. So this is how each of these treatment modalities and their strategy, depending upon the disease pathology which mandates its use. But what we need to understand in terms of advancements, we do have the newest FDA-approved varenicline as a nasal spray for stimulating tear production, but still not available in India. Probably could try online. Understanding punctal plugs, temporary punctal plugs, permanent punctal plugs, which conditions you need to use them, assess the ocular surface tear inflammation before you use your punctal plugs here, use of temporary plugs before you would permanently plug these patients. So these are going to be victims when we are looking at anti-inflammatory modulators, lifitegrast, which is the LFA1 antagonist here. And I think all these are available in any of your textbooks to go and update yourself on the pathogenesis and the mechanism of action of lifitegrast, which can be used as a 5% solution. The onset of action is been recommended as early as 2 weeks, but perhaps this still is comparable to the available immunomodulator of cyclosporin in dry eye disease. So this is a second anti-inflammatory which has been advocated and FDA approved here. We also have the newer one, Oxervate, or the semi-German, which is the only recombinant human growth factor which is used for neurotrophic keratitis to treat dry eye disease here. Biological topicals and ocular surface, I would recommend you to read this comprehensive review, which will talk to you about the serum-derived topical agents, the platelet-derived topical biological agents, the amniotic membrane-derived topical biological agents, which all help in increased epithelial healing, have some amount of anti-inflammatory property, and you also have the ocular surface immunoglobulin therapy. These have led on, or these are also become part of targeted therapy modules for dry eye disease, and we have low dose heparin drops, which acts on the nuclear extracellular traps, which form micro mucocellular aggregates on the surface on patients with particular categories of dry eye, such as severe ocular GVHTs, severe SJs, severe Sjogren's here. And this is another medication, uses 100 international units, which will really help you here. What is new in the understanding is the discovery of nets on the ocular surface, the ACPs, which is called, which is the anti-citrullinated protein antibodies, and the nets on the ocular surface, which lead to refractory dry eye disease, and targeted therapy to decrease the nets and the ACPAs on the surface by using topical human immunoglobulin therapy is something which is now on in practice for the last 4 or 5 years here, and this really helps you to give control that subset of refractory dry eye disease in patients who are present with severe dry eye disease, such as an ocular GVHT, and severe SJS, and severe Sjogren's, and likely subsets of diseases. So this is representative pictures following treatment with topical recombinant DNAs, which particularly acts on the ocular surface nets and helps to decrease the refractory ocular surface inflammation here. We do have several devices which act on those patients who have lid pathologies, who have the meibomian gland pathologies of the lids, and these can vary from LipiFlow, which are simple thermal pulsative devices. You have intensive pulse light devices. You have the newer, the quantum magnetic field devices, the QMR molecular resonance, which also helps to treat the lid gland pathologies here. Have the Rexon treatments. So a variety of these are now available. And among the other devices, you have the Procera, which is again an assembled amniotic membrane device where you need surgical interventions for your patients here. Something which works effectively all the time is your could use the PROS contact lenses, and where PROS is not affordable, effective use with your with scleral contact lens pair, you need a devoted team of your physician and optometrist working in tandem. And these are some of the clinical pictures of chronic SJS patients who are in follow-up with me on after long-term scleral contact lens therapy, which works both refractory, both as therapeutic and refractive rehabilitation of such patients here. So I think you have an armamentarium of devices in front of you, but understanding the disease pathology is important in management of dry eye disease here. Would recommend our book, Postgraduate Ophthalmology, for those of the students who would like to read it. And I thank you for the opportunity for presenting and talking to you on dry eye disease. Thank you.
Thank you so much, Dr. Vanity ma'am, for your extensive coverage on the topic of dry eye disease. Now, dry eye disease has become of more importance in today's time with increased use of digital device viewing and increased cases of computer vision syndrome. So the topic is now open for discussion with the expert panelists. Can we have Dr. Josephine Christie ma'am to give her input on this topic?
Good morning, all. I think Vanati ma'am had covered from the basics till the advanced recent advances and all the other the recent developments on dry eye managements also. So, but still, I see most of us still rely on the clinical symptoms, the signs, and the Schimmer's test, and so that is how we address dry eye disease. And so this will be question for you also, ma'am. Like, what do you, how do you give anti-inflammatory, like let's say cyclosporin eye drops? What is your preferred duration of giving cyclosporin eye drops for people with chronic dry eye? What is the commonest recommendation?
I think there is a lot of thrust from the industry to now start cyclosporin drops right away along with your steroid drops. They claiming because of the different formulation modalities which they use, and they claim that those are going to be effective and going to start alongside your steroids. But I think our time-tested adoption of first increasing this or optimizing the surface with enough amount of lubrication therapy, the frequency required, and the judicious or cautious adoption of anti-inflammatory therapy when you're using steroids, depending upon the potency, the frequency we are using, calibrating it to the surface disease. And I would always prefer using your immunomodulators subsequently, even maybe after 2 weeks of your initial optimization, in chronic dry eye disease. And I also adopt the strategy as we do in allergic disease of waxing and waning, the severity of the topical anti-inflammatory agents here. And most of the time when I use immunomodulators, I use them for a cycle of 4 weeks, then probably take it off for 4 weeks and then add it on if you need in. I do use mixed immunomodulator therapies where I'm using teofilm, cyclosporin, and also use it along with the over-the-lid tacrolimus, which depending upon and severe patients here. And there are, I think you would agree, there's a severe subset of dry eye disease patients where cyclosporin 1% is perhaps going to be required, and that needs an in-house formulation here.
Yes, ma'am. Fortunately, we have one formulation of cyclosporin in 2%, which is available in oral lab called as Zorosporin 2%.
Yes.
But I think for the maintenance dose, the cyclosporin 0.1% is working well. Like as you told, initially starting them with steroids and then tapering them and then putting them on a maintenance. So do you prefer cyclosporin over tacrolimus, or is there any recommendation there, ma'am?
For pediatric patients and for long-term severe dry eye disease, over-the-lid applications really helps in terms of maintaining the compliance of the patients in for long-term therapy. But there are groups where you have to give more, and there are groups which prefer only to use topical cyclosporin as well. So I think it depends on your clinical judgment of what is going to work best in which patient.
Yes, and one more question, also open to the panelists, like I have not personally used these LipiFlow devices for Meibomian gland disease. So if someone has used, we'll be happy to hear your opinions on that.
I've used in a couple of patients, but it's an expensive disease and it works for moderate dry eye only, mild to moderate. And I mean, when we were having a discussion recently, also we were discussing for this mild to moderate, if you're doing your hot fermentation and your massage properly, it works.
Yes. Yeah.
So I think the use of these machines and the use of these therapy is mainly for mild to moderate. I think the house will agree with me.
Yes.
And so that's what it is. But the only thing is, yes, for some subset, they really felt good. I tried in one of those which had a little severe. It backfired. There was more inflammation than I anticipated. So we didn't do for the other eye, just after the first. And it needs at least a minimum of 3 sittings. So it is a little longer process. And
the cost is also an
cost is and that's what it is. So, but if properly, like if hot fermentation and massage is properly taught, it's fine. Nowadays, when we were PGs, we were also actually taking out the lipid, the discharge which used to come out. I feel that LipiFlow is doing the same thing.
Yeah, we used to insert the lid spatulas
We had that
scrape
now
on them. Yes.
Now we hardly nobody's doing that because now you have these machines to do it. It was just as PGs we had to do it, It was not part of our.
I think Dr. Bhavna needs to go so we can take her talk and then move on. Yeah.
Yes, ma'am.
Thank you so much, Vanati ma'am, for that comprehensive presentation. I would like to invite our next speaker, Dr. Bhavna Sharma ma'am. Ma'am, you can share your slides.
Are the slides visible? I'm audible.
Ma'am, the slides are not visible. We can hear you.
Are they visible now?
Yes, ma'am.
Thank you. Very good morning, and I'm thankful to the AIOS for giving me this opportunity to speak here today on this very important topic, that is corneal dystrophies and degeneration. And this topic is one of the most commonly asked topics in exams in your practicals. So though it is a vast topic, I would want to cover it in short and of course try to simplify it as well. So it is a fairly common spectrum of disorders and lead to structural and functional damage of the cornea. Hence, it is important that we know the clinical features, differentials, and pathology. When we differentiate corneal dystrophies and degeneration, the corneal dystrophies mainly are inherited disorders, and they're not associated with any systemic disease or any age factor or any environmental factors. and hence they are also seen in early part of the life, that is early childhood, early adulthood. They are bilateral, symmetrical, and slowly progressive disorders, mostly central and associated with abnormal material deposition. While corneal degenerations are acquired conditions, they are generally secondary to systemic factors, environmental factors, inflammation, trauma, etc., and hence they're commonly seen in increasing age. And also, because of the same reason, it is seen mostly in bilateral cases, and there may be symmetrical presentation in those cases. They involve mostly the peripheral, some may involve the center as well, and associated with vascularization, lipid deposition, and degenerations. As I said, that the degenerations are because of environmental factors, age, and abnormal deposition in these. We would take one by one the degenerations which one comes across commonly in the clinical practice. So we commonly see the spheroidal degeneration. So the spheroidal degenerations are deposition of these golden or amber colored translucent vesicles over the cornea. They may involve the central and hence they may interfere with the visual acuity, and sometimes when severe and coalesced deposits, they significantly cause structural damage as well as the visual acuity deprivation. Arcus senilis is frequently seen as an age-related condition, and this deposition of lipid lipoproteins in peripheral cornea. Band keratopathy, or the BSK as it is known, that is the calcium deposition in Bowman's membrane and superficial stroma, which is associated with chronic inflammation, chronic uveitis, hypercalcemia, etc. Salzmann nodular degeneration again is a condition which is associated with inflammation, and it is in clinical practice, it is these are white elevated nodules, mostly bluish white. It's seen on the corneal surface towards the periphery, sometimes may involve the center as well. The Tyrion's marginal degenerations, they are the lesions which are present in the superior part from superior 10 o'clock to 2 o'clock, and these are the peripheral degenerations associated with thinning and significant ectasia. The pellucid marginal degeneration, as opposed to the Tyrians, is seen as the inferior quadrant extending from the 4 to 8 o'clock, and we characteristically see the crab claw or the kissing dove sign on the corneal topography. The Hassel-Henle bodies, these are small hyaline excrescences on the posterior surface of the Descemet's membrane and mostly seen in the periphery. They may not interfere with the visual acuity and they may not require any intervention if in early stages. The Vaux white limbal girdle, these are flower-like deposits seen in the periphery of the cornea, mostly the nasal and temporal part, bilateral, and of course they're age-related. Dellen, this is a condition because of tear deficiency, abnormality in the periphery of the cornea because of some raised limbal lesion or some raised swelling at that area, resulting into compaction, dehydration of the stroma, and thinning at that site. Pingingula, we are aware that it is an elastotic degeneration, like a yellowish elevated gelatinous patches, mostly on the temporal part of the conjunctiva. Pterygium, it is the fibrovascular degeneration of the subconjunctival tissue. So how do we manage corneal degenerations? The corneal degenerations, if they're not obstructing vision, in the early stages, they're not interfering with the structure of the cornea, they can be treated medically with the help of lubricating eye drops. You can give spectacles and contact lenses for visual correction. You can, of course, the management of underlying systemic condition is important in these cases. Surgical therapy is required in more severe involvement, where they're involving the deeper layers, like superficial keratectomy or the PTK for superficial deposits like in Salzmann degeneration or BSK. The collagen cross-linking is advised for patients of PMDs sometimes. Lamellar keratoplasty, penetrating keratoplasty are required depending on the depth of the lesions. And we can also have intracorneal ring segments intact when there's ectasias or when there's structural involvement. The corneal dystrophies, as opposed to the corneal degenerations, is something which is inherited. These are the genetically determined disorders. And to start with the specific corneal dystrophies, let me clarify these few points which are important to understand dystrophies, that they have mainly associated with genetic mutations. Some of the genetic mutations have been identified and they've been mapped to particular genes, whereas others have not yet been identified. These mutations, they cause transcription or deposition of aberrant proteins, and the pace of this deposition, it determines the natural history or the severity of these diseases. Up till now, what we were seeing that the anatomical location of the lesion was mainly the criteria for categorization of these dystrophies, like when it is an epithelial dystrophy or a Bowman's dystrophy or stroma or endothelial dystrophies. However, because some dystrophies also extended beyond one layer, and they were like an epithelial dystrophy would involve the stromal layer, so they were again recategorized, and we went on to the IC3D classification of these dystrophies. That is IC3D classification, which was given earlier in 2008, and we have now the third edition that was updated in 2024. So the first edition, it gave us some templates about the clinical and pathological information. In the second edition, we had the TGF beta induced dystrophies, and the third edition, it has further modified and it has added an entirely new category, that is the epithelial recurrent erosion dystrophies and the PPCDs, and also some of the dystrophies are more clearer with regards to their genetic mapping. So these are the categories of dystrophies one must know, that is from category 1 to category 4. Category 1 is one in which the phenotype is well described as well as the gene has been mapped to a specific location and the specific mutation is known. While in category 2, it is though a well-defined phenotype, the genes have not been identified. However, it has been mapped to one of the chromosomal loci. The category 3, the phenotype is well known, but neither the gene has been mapped or the chromosomal identification is there. Whereas category 4 is the disorders where it may be a suspected dystrophy, but the evidence is still required to convincingly say that it is a dystrophy and it is genetically associated. So with the ICD-3 classification, we have the epithelial and subepithelial dystrophies, the epithelial stromal dystrophies, that is the TGF beta induced dystrophies, and stromal and endothelial dystrophies. This is the detailed table of which I have compiled for the dystrophies which come under which category, like the epithelial and subepithelial, the first category, to the second TGF beta induced stromal and the endothelial dystrophies. So in the epithelial dystrophies, epithelial and subepithelial dystrophies, we commonly encounter the epithelial Bowman's membrane, basement membrane dystrophy, or the EBMD, the EREDs, Meesmann and gelatinous drop-like dystrophies. The stromal, epithelial stromal or the TGF beta induced dystrophies are mainly the RBCD or the and Thiel-Behnke dystrophies, the lattice and the granular corneal dystrophy. The isolated stromal dystrophies comprise mainly of the macular corneal dystrophies, Schneider's, congenital stromal dystrophy, and central cloudy dystrophy of Francois. The endothelial dystrophy are the FECD, the PPCD, congenital hereditary endothelial dystrophy, and the X-linked endothelial corneal dystrophy. With this backdrop of information, we would take now these individual dystrophies in details, and I would be describing them in the phenotypic and the genetic determination of each dystrophy. I have compiled this table for you all to simplify the dystrophy in terms of their layers involved, the gene locus, the inheritance pattern, and to which category does it fall. So first we take the epithelial dystrophies. So epithelial dystrophies, the first or the most common dystrophy which we come across is the EBMD, or the map dot corneal dystrophy. So in map dot corneal dystrophy, as the name suggests, we see various patterns like maps, dots, or fingerprints. They're generally asymmetrical in the form of irregular grayish opacifications, and they may be clustered at one point, or they may be isolated, single opacification may be seen. And one of the important sign which is seen is the corneal valance, or the Shahinian sign. Here you see a sort of a Shahinian image, that there's a scalloped horizontal line of tear film thinning in the superior part, and that is seen because of the irregular deposition, irregular corneal epithelial erosions at that site, resulting into thinning, and the corneal thinning because of this abnormal wetting of the corneal surface. The EBMD is mostly sporadic. However, it has been rarely linked to TGF beta mutation. The Meesmann corneal dystrophy is the dystrophy with formation of clear cyst intraepithelial vesicles, which can extend up to the periphery, and however more in the center part. And the onset of symptoms are generally during the early childhood, and however they may not be noticeable as the patient may not present to you at that time, and there is clear demarcation between involved and the uninvolved vesicles. The Stockholm variant has been described, in which the complete cornea is involved with these fine grayish opacities and formation of these cysts. It is an autosomal dominant inheritance, and the mutation has been linked to these two genes. The gelatinous drop-like dystrophy, it is forms a mulberry-like lesions in the cornea. There's formation of multiple grayish elevated nodules associated with superficial vascularization, and this may stain with fluorescence as a result of erosions. And sometimes in advanced cases, you may see the Kumquat lesions like this fruit, which is there, like, formation of these small surface excrescences on this fruit as it is seen. The mutation has been identified, and it is as mentioned here, and it is autosomal recessive. Now, in the ICD-3 classification, there's another addition, that is the epithelial recurrent erosion dystrophies, and it is formed by the spectrum of these three dystrophies, that is the dystrophia Helsing-Glandica, the dystrophia somnolentsis, and recurrent hereditary corneal erosions. The phenotype is there's formation of small lesions, grayish white, circular or wreath-like lesions with central clarity may be seen, and they involve generally the Bowman's layer and the underlying stroma. The lesions may be precipitated by minor trauma, and this dystrophy starts at the early part of the life. And however, with the increasing age, like in third or fourth decade, the severity may seem to decrease. In between two episodes, the patient may be completely asymptomatic. It has got an autosomal dominant inheritance. From the epithelial dystrophies, we move on to the epithelial stromal dystrophy, that is the TGF beta induced dystrophy, or the transforming growth factor induced dystrophies. And this particular mutation, it is linked to keratoepithelium, which is the protein, matrix protein, and which is found to be deposited in these dystrophies. So the first, we would take the Rees-Buckler's corneal dystrophy. The Rees-Buckler corneal dystrophy is the characteristic pattern is the reticular appearance of the deposits, that is the whitish gray opacities in the Bowman's layer, and sometimes they extend into the deeper stroma as well. They cause severe recurrent erosions and significant visual loss in advanced cases as well. And in advanced cases, something like a curdled milk appearance would be seen, like this white opacities would cover the central part completely with hardly any clear area in between. And and the deposits can be stained with mesentricon. And it is again an autosomal dominant inheritance. The second is the Thiel-Behnke corneal dystrophy, and we differentiate the Thiel-Behnke or the TBCD dystrophy in the form, that is the phenotypic form is the honeycomb appearance, and these irregular grayish-white opacities are forming an honeycomb pattern on the cornea. And while seeing an ASOCT, you would see a sawtooth characteristic appearance, that is deposition of the fibrofatty tissue, which replaces that Bowman's membrane and extends into the superficial towards the epithelium. This is how we differentiate between the RBCD and TBCD. That is, the RBCD is more severe, and sometimes the periphery may be involved as opposed to the TBCD, which is less severe. Then we have the lattice corneal dystrophy. Now, the lattice corneal dystrophy is, as the name suggests, there is formation of these lattice-like refractal lines of amyloid deposits in the cornea, in the corneal stroma, and they are associated with frequent erosions, and the presentation may be seen in the first and the second decades. It may cause epithelial atrophy, and it is an autosomal dominant inheritance as for all TGF-beta induced dystrophies. So the lattice corneal dystrophy again has got the four forms have been described. The type 1 and type 2 have a fairly earlier occurrence in the life, that is in the first and the second and the third decade. The type 1 is associated only with the corneal amyloid, that is in the corneal manifestations are there, wherein this type 2 there may be systemic amyloidosis. It is associated with peripheral nerve involvement or skin deposits may be seen, while the type 3 and type 4 deposits, the type 3 and type 4 lattice dystrophies are seen with advancing age, and their autosomal recessive, and larger lesions would be seen in these cases. From there, we also, yes, after lattice, we see the granular corneal dystrophy. So the granular corneal dystrophy can be either type 1 and the type 2. How to differentiate type 1 and the type 2 is the type 1 is a well-defined crumb-like opacities in the central superficial stroma, like somebody would want to describe it like a snowflake lesion, with a clear intervening stroma, and periphery is generally spared. Whereas the granular type 2 or the avalinar dystrophy as it is known, it is a mixed sort of a presentation with granular and lattice-like opacities, with wide granular, slightly larger than the granular type 1 dystrophy opacities, and also the lattice lines like the short lines which do not intersect, and also both have the autosomal dominant inheritance. And this is how we differentiate between the granular and the granular type 2 dystrophy. So the onset is early in granular type 1 as compared to granular type 2. And the granular type 2, as I said, that it is associated with deeper lesions and at both lattice and the granular type pattern. From the epithelial stromal TGF beta dystrophies, we move on to the stromal dystrophies, and the stromal dystrophies would be the granular, the macular, the Schneiders, and the others which you would be subsequently taking. Here, I would also want you all to remember this mnemonic for granular, macular, and lattice dystrophy. It tells us about the inheritance pattern, the type of deposit here, and how would you stain, what is the stain employed for the identification of these deposits. The third type is the stromal dystrophies, and these are non-TGF beta induced dystrophies. And the first we would take is the macular corneal dystrophy. So the macular corneal dystrophy, as we are aware, is more serious variant of the stromal dystrophy. It appears as diffuse grayish-white stromal opacities without any clear zone of clarity without any clear zone in between these lesions, and it causes corneal thinning. Recurrent erosions can involve the deep stroma as well as the epithelium and causes severe visual loss and extends up to the periphery as well. It is an autosomal recessive inheritance pattern. And the immunotypes of macular corneal dystrophy, it depends on the antigenic keratin sulfate. So the type 1 has the keratin sulfate, which is, the keratin sulfate is not detected in either cornea or the blood serum. Whereas in type 1A, you may see antigenic keratin deposition in keratocytes, that is the stroma, while not in the serum. Whereas type 2, the normal amount of keratin sulfate would be seen in the cornea and the blood serum as well. The second type which we want to take is the Schneider's corneal dystrophy. So the Schneider's dystrophy the phenotype is we see central crystalline needle-like crystals, white amorphous deposits of cholesterol and phospholipids in the stroma. And sometimes because it is a hypercholesterolemia condition, you may also be seeing a corneal arcus formation. It is an autosomal dominant inheritance. Then we have this congenital stromal corneal dystrophy. These are bilateral, symmetrical, sort of milky white opacities which are present in the stroma, and they're seen in first few months of life. And however, the good thing is that they're non-progressive or they're slowly progressive. The inheritance pattern is again autosomal dominant. We take the last part, that is the endothelial corneal dystrophies. So again, I have simplified all endothelial corneal dystrophy in this table. It includes the phenotype, the inheritance pattern, the onset, symptoms and sign, and the pathology associated with it. So first we take the FECD or the Fuchs endothelial corneal dystrophy. Here you see the hallmark is the formation of guttae or the excrescences or the Descemet's membrane, and also the DM thickening and endothelial cell loss associated with it, leading to the corneal edema and bullous keratopathy at the later days. They are generally sporadic, but sometimes some familial forms have been shown to be associated with this disorder, and some genes have been linked to this. How do you classify the severity of FECD? So the severity grading of FECD can be stage 1 to stage 4, where in stage 1 you have few corneal guttae with thickening of the Descemet's membrane, whereas in stage 4 it is a severe involvement with persistent edema and endothelial cell count to decrease less than 500 cells. Depending on the cornea guttae also, you can classify the FECD. Then we have the second important dystrophy, that is the congenital hereditary endothelial dystrophy. It is again a category 1 dystrophy. The phenotype is we have got asymmetrical, cloudy, milky white ground glass appearance of the cornea, and it is a bilateral condition. There is a diffuse corneal edema which is present in the early part of life and may be associated with nystagmus. As I said, that it is an autosomal recessive, and the specific mutation has been linked to SLC 4A11 gene. Then is the CHED. One thing everyone would want to know is that earlier there was CHED1 and CHED2 classifications. Now with the ICD3 classification system, we have the CHED2, which has been classified now as the CHED, and there's no CHED1. So the CHED1 has because the phenotype was similar to PPCD, so it is now classified as the PPCD only. So the main features of CHED is that it is a ground glass haze, which you see, and it involves all the layers of the corneal stroma in early part of the life. How do we manage CHED? Is that in mild disease, moderate and severe. In the mild disease, you may want to give a medical management as compared to moderate and severe, which require either a lamellar keratoplasty depending on the layer involved, and the severe, you may require a penetrating keratoplasty. The posterior polymorphous corneal dystrophy, the PPCD, as the name suggests, there's a polymorphous sort of form, phenotypic signs are seen. There's formation of vesicular, band-like or geographic lesions on the Descemet's membrane, and the typical pattern is the rail track opacities or the serpentine lines which may be seen, and it results in corneal edema and sometimes associated with iris abnormalities and raised IOP. So the corneal dystrophies are managed by visual rehabilitation mainly, that is, you can do a refractive correction or low vision aid if in advanced cases, whereas medical management comprises of lubricants, bandage contact lens, hypertonic saline if there's corneal edema, and IOP reduction. The surgical intervention, as I said, depending on the layers involved, it can be the PTK in the superficial layers to a lamellar keratoplasty and a full thickness keratoplasty if all the layers are involved. So what we look forward is the gene therapy for management of these conditions and pharmacological treatments which are in the developmental stages and tissue engineering. Thank you very much for your patient hearing. If there is time, hello.
Yes, ma'am.
Yeah, Dr. Anu, if there's time, can I take some clinical scenarios?
Yes, ma'am.
Okay. So these clinical scenarios which I've made is they may be asked in exam, like a case 1, a 17-year-old girl who presents for a routine checkup. She has no visual complaints, but on slit lamp you find these discrete crumb-like opacities in the central anterior stroma. The father also gives a similar history of visual loss. So what would be the diagnosis, mode of inheritance, and the histological findings here? So as per the mnemonic, which I already told, that it could be a granular dystrophy with an inheritance pattern, autosomal dominant, and the hyaline deposits which stain with the meson trichome. Similarly, a case like this with an elderly female presents with blurring of vision, which is worst in the morning, and you see corneal guttae and disc edema and corneal edema. So it could be a case of FECD. And the last is a case which presents a young male who presents with recurrent erosions and these findings of irregular lattice-like deposits. So what could be the diagnosis and how would you manage this case? So this could be a case of EBMD, and the treatment could be the lubricating drops and ocular surface management in these cases. That is all for my side. Thank you very much.
Thank you so much, ma'am, for that informative presentation. And you have very well covered the clinical perspectives as well. I'd like to invite our expert panel for the inputs or comments on this. Dr. Nikhil, sir.
Yeah, I think a very extensive, nice talk by Dr. Bhavna Sharma. And I'm not sure whether we touched upon, but maybe about the management aspect. That's totally, I think, another chapter of a PG webinar or something like that. But that could be also broadly like surgical, non-surgical, contact lenses, all these type of, could be probably discussed maybe on another day. But a nice talk with good pictures, and I think it would be helpful for all.
A very comprehensive and a very beautifully presented, very complex topic to take care of, Professor Bhavna. The only thing which I would again stress for the PGs and for all the practitioners here would be when we're talking of these recurrent corneal erosions, which is actually a very, very common scenario in our clinics. And especially now with the refractive surgery going very high. So to diagnose these epithelial and anterior stromal dystrophies is very, very important. And that sometimes, if it's not done on time, doing refractive surgery, maybe a LASIK, would lead to more of these erosions. And just doing a PRK in those cases would be both the treatment as well as not causing any future problems to that patient. So I think here I feel that this is very, very important, and diagnosing that on slit lamp should be encouraged. So your thoughts, Professor Bhavna and Dr.
Yes, of course, ma'am. That's very important that with very frequently patients coming to us for refractive procedures, one must be able to diagnose these dystrophies, particularly the epithelial and the Bowman's membrane related dystrophies. And we should be able to identify clinically these dystrophies and for an appropriate diagnose, for an appropriate counseling actually in these cases. Yes, I do agree to that, ma'am.
And genetic counseling these days has become very, very important. And in most of the institute now, there are genetic counselors. So if any patient is there, the pedigree and referring to a genetic counselor is important. And having an ophthalmic genetic counselor is something which really helps these patients. So like in our hospital, we now send to the genetic counselors, and suddenly we come to know, the family trace like this, and future also can be done. So like all dystrophies should at least be sent to the counselor if there's one around.
Thank you so much, Bhavna ma'am, for this very elaborately covered topic. And as newly joined postgraduates, I feel all of us have struggled to correctly classify the dystrophies and degenerations. So thank you so much, ma'am. Without further ado, we would like to move on to the next talk by Dr. Veena Pillai ma'am on corneal collagen cross-linking. Welcome, Veena ma'am. Can you please have your talk, please?
Yeah. Just I'll share.
Yes, ma'am.
Yeah. Is it visible, madam?
Yes, ma'am. Your screen is
Yeah.
visible.
Yes, yes. Thank you. Thank you. I thank AOS for giving me this opportunity of sharing corneal collagen cross-linking. So can I, actually it is not coming full screen. Some of the parts are. Okay, so here this collagen cross-linking, first I want to divide it into three parts. There is the discussion, and there are specific learning objectives for postgraduates. First, they need to understand the background and introduction and basic concepts what are involved in corneal collagen cross-linking and patient selection. And in the second part, I'm going to discuss about surgical techniques and variations in surgical techniques, effects and safety, cross-linking applications, complications, and special situations. And in part 3, I'm going to discuss about advanced cross-linking and summary and study trials. There is no financial interest in this topic. And for now, I'm going to discuss about the introduction. Corneal collagen cross-linking is a minimally invasive procedure used to prevent progression of corneal ectasia, such as keratoconus and post-LASIK ectasia. Corneal collagen cross-linking is a surgical procedure to strengthen the cornea using riboflavin as a photosensitizer with the help of the UV light. So it is used to halt the progression of the corneal ectasia like keratoconus, pellucid marginal degeneration, other refractive surgery, post-refractive surgeries ectasias. The procedure involves applying the riboflavin drops and then exposure to the UVA light and forms the new bonds and makes the cornea stiffer.
So important considerations. So it is not a cure, and see, this corneal collagen cross-linking is not going to cure the disease, and it is not reverse the existing damage, but only stops the progression of the disease, and sometimes there is mild reduction of the astigmatism. And best for progressive cases, it is most effective for patients with progressive corneal ectasia like keratoconus. And it is a minimally invasive procedure. And coming to the background, collagen cross-linking, the ability of the collagen fibrils to form strong chemical bonds with adjacent fibrils. So in the cornea, this collagen cross-linking occurs naturally with age due to an oxidative deamination reaction. So that's why this is not happening in the adults as the age is going to the after 35 years. Usually this natural cross-linking will protect the person from the keratoconus progression. So it has been hypothesized that the natural cross-linking explains why keratectasia is often progresses most rapidly in adolescents and early adulthood, but tends to stabilize in patients after middle age. So while cross-linking tends to occur naturally over time, there are other pathways that may lead to premature cross-linking. One is glycation. A reaction seen predominantly in people with diabetes can lead to the formation of additional bonds between collagen. And second one is oxidation, has also been shown to trigger the cornea cross-linking through the release of oxygen-free radicals. So coming to the basic concepts of cross-linking. So here, the riboflavin and ultraviolet A light. So in this technique, the corneal tissue is strengthening by using riboflavin as a photosensitizer, and UVA is to increase the formation of intra and interfibrillar covalent bonds by photosensitized oxidation. So after here what we are saying, before cross-linking and after cross-linking, there are multiple bonds are formed that will strengthen the cornea. So initially, the basic concept that is developed in the it is in the Dresden University late 1990s, who used UV light to induce collagen cross-linking via the oxidation pathway in the riboflavin-soaked porcine and rabbit corneas. The resultant corneas were stiffer and more resistant to enzymatic digestion. Treated corneas contained higher molecular weight polymers of collagen due to the fibril cross-linking. So safety studies also showed that corneal endothelium was not damaged by the treatment if proper UV irradiance was maintained and if the corneal thickness exceeds 400 microns. So here, human studies of UV induced corneal cross-linking began in 2003 in Dresden. The initial pilot study enrolled 16 patients, and they noticed 100% of the patients, they stopped progression of the after cross-linking treatment. And 70% of the patients, there is flattening of the steep anterior corneal curvature, and 65% of patients are visual acuity is improved. And in 2011, next, this cross-linking relies on a photosensitizer and UV light source, which together produce photochemical reaction. Now, first, riboflavin, UV light, and photochemical reaction. So, riboflavin is a photosensitizer, and if in cross-linking, the photosensitizer absorbs the light of 370 nanometers, and it is systematically safe molecule that can be adequately absorbed by the corneal stroma through the topical application when the epithelium is removed. Second one is UV light, we need to understand. It is stimulating a photosensitive reaction with riboflavin while at the same time protecting other ocular structures. The total fluence required for cross-linking with UVA light is 5.4 joules per centimeter square. Here, the cross-linking fails to be effective once the energy intensity exceeds 45 microwatts by centimeter square. This is according to the Bunsen-Rosen law. The effect of photochemical reaction should be similar if the total fluence remains constant. So based on this, accelerated cross-linking was used. And photochemical, coming to the photochemical reaction, here the riboflavin generates reactive oxygen species, which induce the formation of covalent bonds between the adjacent collagen molecules and between collagen molecules and photoglycans. The presence of oxygen is essential for this process. So this is the how the UVA light is exposed to the riboflavin soaked cornea, and after the treatment, you can see the bond strength is increased. So these are the tools and instruments that are required for the treatment. And coming to the patient selection, here it is while considering the patient selection, we have to discuss about the indications. The primary purpose of the cross-linking is to halt the progression of the ectasia. Therefore, ideal candidates for this therapy are individuals who are documented progressive ectatic diseases. The most common indications of keratoconus are common indication is keratoconus. The other indications are pellucid marginal degeneration, Terrien's marginal degeneration, post-refractive keratectasia. And while other are currently no definitive progressive while there is currently no definitive progression criteria for cross-linking, parameters to consider include changes in the refraction, uncorrected visual acuity, best corrected visual acuity, and corneal shape. These are the parameters we need to consider before taking the patient for procedure. The contraindications for this cross-linking is corneal thickness is less than 400 microns, prior herpetic infections, because after treatment, this herpes can be reactivated, and concurrent infections and severe corneal scarring and opacification is present to the patient, and history of poor epithelial wound healing, severe ocular surface diseases like dry eyes, and autoimmune disorders. So now so I'm going to discuss about the part 2. This is surgical technique, effects and safety, cross-linking applications and complications of specific situations. Surgical techniques. So the standard treatment protocol called the Dresden protocol was formulated by Valencek et al. For corneas with minimal thickness of 400 microns. So initially we need to debride the cornea, and after that we have to, in sterile conditions, we have to do this procedure. After that we have to take the corneal thickness and instill the topical anesthetic eye drops in the eye and debride the central 7 to 8 millimeters of corneal epithelium, and we have to instill the drops every 3 minutes for 30 minutes. Simultaneously after 30 minutes, and again we have to take the corneal thickness and expose the UVA light about 370 nanometers and 3 milliwatt centimeter square for 30 minutes. So after finishing of the procedure, after 30 minutes, we have to apply the topical antibiotics and soft contact lens, which is having good oxygen permeability. Next, variations in surgical techniques of cross-linking. First, riboflavin delivery system. So one is epithelium off method and epithelium on method. In epithelium on method, the epithelium is manually debrided to enable the better penetration, and it is most effective procedure. And epithelium on method, it is transepithelial method. Even though debridement induced complications like postoperative pain and corneal haze are avoided in this method, but it demonstrates lower effectiveness with this method than with epithelium on cross-linking. Coming to the osmolarity, hypoosmolar riboflavin is used in thin corneas, 320 to 400 microns, to thicken the cornea and to a minimum of 400 microns. So this is illustrative diagrams of various modifications of corneal cross-linking, and just it is showing all epithelium off method and transepithelial method and ionotoporosis and hypoosmolar riboflavin technique and customized protocols. So and lenticules, using the lenticule assisted cross-linking and contact lens assisted cross-linking. So here variations in surgical techniques. So UV exposure, here treatment time is accelerated cross-linking. This is based on Bunsen-Russell law of photochemical reciprocity describes the linearly proportional photochemical effect to the total EV energy delivered, regardless of the duration of the administration. So based on this accelerated corneal cross-linking is used. So here the dose is 10 milliwatts per centimeter square for 9 minutes, has been better therapeutic and safety profile than higher irradiation doses for shorter periods of time. So, and positioning, traditionally, this cross-linking, and another variation is positioning. So usually it is done in the supine position, but the studies are showing they performed at the slit lamp. But the uniform absorption of the riboflavin is a question in this manner. Now coming to the effects and safety, here the cross-linking effects are seen largely in the anterior cornea as riboflavin concentration diminishes with increased depth. The debrided epithelium is replaced within 3 to 4 days. So these are the after effects of cross-linking. And limbal stem cell are not damaged. And the subepithelial basal nerve plexus are obliterated. It starts to regenerate after 7 days. So till that time, there will be some mild anesthesia. And apoptosis of the keratocytes in the anterior stroma will happen in cross-linking, but new keratocytes will migrate inward from the periphery. As the stroma heals, collagen compaction and a hyperdense extracellular matrix are seen. When this corneal cross-linking does not cause any endothelial damage, and it has shown that normal cornea structure will be altered and cellularity at least it will take around 3 months, up to 3 years, sorry, this corneal structure alteration can take place. So intraocular pressure has no significant effect. So coming to the applications, already discussed keratoconus, marginal degeneration, ectasia, bacterial keratitis, and bullous keratopathy. So first, keratoconus performs when progression is documented. Advised to stop eye rubbing in keratoconus patients and avoid specific sleeping positions, especially prone or lateral sleeping positions. They may come in contact with the eye, may come in contact with the surface, and it can progress the disease. And to promote the visual rehabilitation as well as stabilize the keratoconus, this cross-linking can be combined with refractive surgery. That is example, corneal cross-linking plus, and Athens protocol also telling this is topography guided PRK followed by cross-linking. Cross-linking with intracorneal stromal rings also described, and there are to have the better visual acuity after cross-linking, phakic IOLs also can be done. So second one is pellucid marginal degeneration. It involves the inferior peripheral cornea. Cross-linking by decentering the focus of the irradiation to the involved zone, pathological site. And reports are suggesting that visual acuity, keratometry, and astigmatism parameters are improved. And ectasia following refractive surgery, third indication. Here, this cross-linking can stabilize the post-LASIK ectasia and improves the visual acuity and keratometric parameters. Here we can, in Athens protocol also, we can try cross-linking with PRK and LASIK extra. This is planned procedure with LASIK is followed by modified cross-linking with goal of preventing post-LASIK ectasia. So fourth indication is photoactivated chromatophore for infective keratitis. This provides resistance to enzymes produced by the bacterial and fungal pathogens. So this will strengthen the cornea and avoid the melting of the stromal melt. So in multi-center study, it is shown that antimicrobial therapy group achieved 90.5% success, whereas this PAC group they attained 88.9%. So there is not much clinical significance between two groups. So only cross-linking is currently considered only in cases resistant to standard antimicrobial therapy. Other applications are bullous keratopathy. So here it will reduce the corneal edema and lasts only for 6 months. So it is short-term therapy. And complications. So most common complications are temporary stromal haze, up to 70% of patients in the early phase, and but it will heal within few. Haze will be cleared, but some patients, they report 10% of patients report with the permanent haze. So second complication is corneal scarring and sterile infiltrates, infectious keratitis, and diffuse lamellar keratitis in post-LASIK patients. So these are the patients who initially on the first day noticed some corneal haze, but after 3 months the haze is reduced. And this is another picture with the OCT documented, and corneal edema. So initially the corneal is thickened, edematous, and after follow-up of 15 days, it is edema is decreased. So here, transient corneal haze and persistent corneal haze. Transient corneal haze is a secondary to the condition due to increased collagen fiber diameter post collagen therapy, and this is not associated with visual disturbance and often regress after 12 months. But persistent corneal haze lasts beyond 12 months, negatively impacts visual acuity, thought to be secondary to the ongoing keratoectasia and corneal remodeling. The risk factors, preoperative risk factors are if the corneal thickness is less than 400 microns, or presence of preoperative activated keratocytes in the anterior stroma, one of the risk factors, and intraoperative risk factors are defocusing of the UVA source and lack of riboflavin availability during irradiation. Excessive riboflavin dextran, 20%, that is also one of the reason, because it will increase the thickness of the cornea and prevent the deeper penetration of the UVX. And postoperatively, no compliance with the topical corticosteroid therapy, infective keratitis, therapeutic lens intolerance, and presence of Langerhans cells after contact lens removal. So cross-linking in special situations. So pediatric keratoconus. Keratoconus in children tends to be aggressive and associated with an unfavorable prognosis and an increased need for the corneal transplant. So in these patients, this corneal cross-linking is advised immediately without the need for documenting progression. As these children, the progression is will happen as the growth of the child is happening because of the hormonal changes. This will be progressed. So without need for the documenting, once it is diagnosed, better advised for go for the cross-linking. So in some of the studies, Sienna pediatric cross-linking study, they conducted rapid functional improvement after cross-linking and better long-term stability is noticed in these patients. So patient with thicker corneas did better than the patient with thinner corneas. And coming to the thin cornea, special situation, here the corneas with minimal thickness of 350 microns, hypoosmolar riboflavin solution used to induce corneal swelling. So, but cross-linking effects are not compromised as the anterior stroma remains the same while the posterior cornea stroma swells. So, and corneal ectasia in pregnancy, other special situation is, in the pregnancy, the hormonal changes that can negatively impact the corneal biomechanics. So these pregnant people can be monitored closely with patients with keratoconus and patients who underwent recent refractive surgery. And cross-linking is avoided during pregnancy due to possibility of complications. And if cross-linking performed, ectasia may progress during subsequent pregnancies. That we need to inform to the patients because of the hormonal changes. So advised to avoid hormonal contraception methods, those who are already suffering with keratoconus, because these hormones can allow the progression of the keratoconus. Other cross-linking applications are progressive myopia, refractive surgery, and keratoplasty. So photorefractive intrastromal cross-linking, high fluence cross-linking has also been tried in patients with low myopia to induce subsequent flattening and refractive correction. And scleral cross-linking in axial myopia. By applying the riboflavin to the sclera and exposing the riboflavin soaked sclera to the UVX will strengthen the sclera, but how it is going to affect the retina, that needs to be studied. And use of keratoplasty. So here, to reduce the post-keratoplasty ectasia by cross-linking, the donor corneal tissue before transplantation, we can, before transplantation, donor corneal tissue can be cross-linked. And corneal cross-linking of the corneal periphery 3 months before corneal transplantation could also reduce the incidence of recurrent ectasia in case of keratoconus patients who are undergoing transplantation. And in part 3, it is advances in cross-linking and future directions, summary and studies and trials. Advances. So pulsed cross-linking, it has been postulated that pulsed delivery of UVA irradiation permit better oxygen diffusion into the stroma. The presence of more oxygen may translate to greater effect. Further studies are required to determine the ideal pulsing protocols. And adapted fluence. Thus far, UVA fluence delivery has remained constant at 5.4 joules per centimeter square, irrespective of the cross-linking protocol. But here, Hafizi, he introduced the concept adapted fluence, in which the energy delivered is customized for the cornea, may increase the safety profile of the cross-linking in thin corneas. It remains to be validated. And another thing is LASIK extra. LASIK extra is a procedure in which cross-linking is combined with LASIK. After raising the flap and performing laser ablation, higher concentration of riboflavin is applied to the stromal bed for the 90 seconds. And after this, the interface is washed and flap is replaced. Then half fluence high intensity UV irradiation is performed. Results so far have shown promising, and with better refractive stability and reduced incidence of post-LASIK regression and ectasia. This can be tried in high myopes, those who are having thin corneas and high refractive errors. So advances in other advances are combined treatment with photorefractive keratectomy and phototherapeutic keratectomy. This concept of CXL plus are combined treatments to simultaneously address the disease progression and poor visual acuity. Here, Athens Protocol Manual, epithelial debridement, partial correction of the refractive errors with a after partial correction with a maximum ablation depth of 50 microns using topographic guided photorefractive keratectomy, followed by mitomycin C application and subsequent conventional treatment. All these things are under study. And other advances are photochemical cross-linking, contact lens assisted cross-linking, where the contact lens is soaked in the riboflavin and placed on the thin corneas after the epithelium is off, and it can be radiated with the UVX. And corneal ellagen intrastromal ring segments case in severe keratoconus, where there is enough thickness, corneal ellagen intrastromal ring segments can be inserted, and after this first step, followed by cross-linking, can be safely performed to arrest the progression. And smile lenticule assisted cross-linking. Here, the lenticule can be placed on the thin corneas, and we can apply after epithelium debridement. This lenticule is placed, and this cross-linking can be done after soaking the lenticule in the riboflavin. Cross-linking can be done. So future directions, no invasive cross-linking. Here it is promising, it is showing according to studies, high doses of oral riboflavin ranging from 800 milligrams to 2 grams daily are ingested with 15 minutes of UV exposure from natural sunlight per day and totaling 6 months. So this is showing good results, but at to larger studies need to be conducted. And customized cross-linking based on topography. Customized treatment pattern localized on specific corneal zones to aid the efficacy of the cross-linking treatment in paracentral and peripheral corneas, modifying the radiation to 3 concentric circular zones centered on maximum posterior elevation, a graded treatment pattern. And another thing, future direction is sub-400 protocol. It is adjusting the UVA illumination time and irradiance to achieve safer cross-linking depths while using the same materials and equipments as standard UVX treatment. and oxygen supplementation, because oxygen is the supplementation of the cornea has been shown to improve cross-linking results by increasing the strength and depth of the cross-linking. This is achieved through the wearable boost mask, which creates a hyperoxic periocular environment. And antimicrobial photodynamic therapy, here antimicrobial, in this it utilizes the activation of photosensitizer in the presence of oxygen to kill microorganisms, selective killing of the microorganisms by binding the microorganisms, and it won't avoid the damage to the human cells. And UVA emitting devices, it is these devices are UVA emitting spectacles are used along with the self-administered topical transepithelial riboflavin for 3 hours daily over 6 months. So this can be used in the early stages. If diagnose keratoconus, we can ask if this study proves this will be very useful for those who are having early keratoconus. And artificial intelligence detect keratoconus versus healthy eyes with an accuracy of 0.97%. So here, earlier diagnosis and more timely cross-linking treatment can stop the progression of the disease. Treatment summary. So this is a treatment summary. First, if the corneal pachymetry is more than 400 microns, then conventional cross-linking and accelerated cross-linking. If pachymetry is less than 400, we can use the contact lens soaked in the riboflavin, and after that we can irradiate the taking the functional pachymetry readings, and do the, if more than 400, do the pachymetry on conventional or accelerated CXL, and pachymetry is less than 400, add drops of distilled water to minimally swell the cornea. So after that, again, we have to take the pachy and more than 400, then accelerated protocol we can use. So summary of the corneal collagen cross-linking image. Here, the basic concepts, riboflavin post corneal ectasia, and this picture is giving all the details about the corneal cross-linking. Madam, is there any time to just go through the studies and trials? If
Yes, ma'am. Please go ahead.
Yeah, Dresden German study. Here, the strength of the study is its large sample size at 1 year, and they clearly documented improvement in best corrected visual acuity after 1 year and after 3 years, and significantly decrease in mean keratometry after the first year. And Sienna eye cross study here strengthened by its large sample size at 1 year and small sample size seen at the 4 years. But here also significant improvement in manifested spherical equivalent at 1 year and after 4 years also. Decrease in mean keratometry by 1 year and 4 years also. And this Australian study, this is also very large study. Here all patients had clearly defined progressive keratoconus and were followed for 5 years. In this, primary outcome results are significant difference in Kmax in all time points. So this study is concluded. This treatment options patients with progressive keratoconus. Here, there is a positive outcome they noted. And US multicenter clinical trials, Evedro study, the presence of an actual sham control group, and control epithelium was not removed in sham control group. So here, large in that group, 204 patients are enrolled. So, and another group is corneal ectasia after refractive surgery, 178 cases are enrolled. So Kmax has decreased by 1.6 diopters in the progressive keratoconus group and by 0.7 in the corneal ectasia post-refractive surgery group from the baseline 1 year. So these trials demonstrate the efficacy and safety of cross-linking for the treatment of keratoconus and ectasia. So conclusion, it is not a cure, but it can reduce some amount of flatten the cornea. By flattening the cornea, astigmatism can be decreased. Best for progressive cases and minimally invasive procedure. Thank you very much.
Thank you so much, Dr. Veena ma'am, for discussing the basic concepts of corneal collagen cross-linking, for discussing the recent updates, and categorically discussing the topic in detail. The topic is now open for discussion with the expert panelist. Can we please have inputs from Dr. Nikhil Gokhale, sir? Dr. Nikhil, sir, are you there?
Yeah, I'm there. I think the presentations are so extensive that unless you have specific questions or something, it's very difficult to give comments. But I think she's covered virtually everything about cross-linking, very comprehensive. And I think that most of the talks today are on those lines. So maybe we can go to the other comments if anyone has.
Yes, sir. Thank you, sir. Dr. Manisha Acharya ma'am, can we please have inputs from your end? Dr. Manisha ma'am? Moving on to Dr. Josephine Christie ma'am, can we please have inputs from your end?
Hi,
Yeah.
sorry. I mean, sorry, Josephine,
Yeah.
sorry.
Please go ahead, ma'am. I'll wait for you.
I think it's a very comprehensive presentation. I think not much to add on whatever has already been said there. I would agree with Dr. Nikhil and Dr. Veena. I mean, Josephine, you go ahead.
Yeah, that was very, very extensive. Dr. Veena, it was very nice. Extensively covered so many things related to C3R. So only thing that I wanted to stress was because keratoconus is also seen with conditions like allergic eye diseases and VKC, it would be very good to attain a good quiescence period before proceeding for CXL, because you might land up in so many other complications, flare up of non-healing epithelial defects and infections. So whenever we see a case of keratoconus, we tend to not see the eye rubbing aspect, or we quickly jump into pentacam, the corneal topography, and then cross-linking. We don't talk or stress more on the eye rubbing aspect and correcting their refractive errors best and offering them a good visual potential. All of these things also has to be given a lot of importance while addressing these patients. So that's what I wanted to add. Thank you, madam. Thank you. Yeah.
Over to you, Anu ma'am.
Ma'am, I have a question, ma'am. Like, how significant are the complications such as infection or corneal haze? Do they meaningfully affect the risk-benefit profile in collagen cross-linking?
The complications such as infectious keratitis are very, very, very rare if done under very sterile precautions. But you can see sterile infiltrates in the periphery. You should have a close watch of all of those things. So addressing all the lid hygiene and the allergy is very important. And regarding the haze, a very little amount of haze can be expected in the initial periods. But after that, we don't see significant haze. But if you go and do a cross-linking in a very high Kmax and a very steep and a thin cornea, haze is very much expected.
I think one point to important is that there are still some centers who do bilateral cross-linking on the same day. And I've had a patient referred to me who had pseudomonas keratitis in both eyes, virtually close to losing both eyes. Both eyes have subsequently had multiple surgeries. So I think one needs to be very cautious, especially when people use contact lens. They use steroids. There is an epithelial breakdown, and the stromal keratocytes are already missing, or there is apoptosis. So one has to be very cautious, especially in using steroids. The question of patching versus bandage contact lens following cross-linking to keep the eye open or closed is always a debate, and each has his own answers. But I think we need to be cautious and avoid bilateral cross-linking at any sort of situation, because that can be a disaster if you have an infection.
Thank you, sir. I'd like to invite our next presenter, Dr. Devi Aishwarya Das, ma'am.
Dr. Devi ma'am, can you please unmute yourself? You're not audible.
Yeah, I'm sorry about that. Good morning, all.
Yes.
So is my screen visible?
Yes, ma'am, your screen is visible and you're audible.
Yes, ma'am.
So I thank AIOS at the outset. So my topic for the day is decoding corneal edema, understanding its mechanism and management. Why I chose this topic is because of its clinical significance and relevance, and how much more clinical it is than just what meets the eye. So I have no financial disclosures. Most pictures are taken from my own clinical setting. However, I've taken the diagrams from some textbooks. So now that hurts the eye. So this is how corneal edema will hurt the patient. So when I take on the topic, I'll be dealing with different sections. What is the disease entity? Its relevant anatomy and physiology of the cornea. Factors that affect corneal hydration. Clinical entities with corneal edema. The diagnosis and the management. Now, so what is corneal edema? It's an increase in the thickness of cornea due to the accumulation of extracellular fluid in the epithelium and or stroma. And why is it relevant? Is because it leads to loss of corneal transparency. So now coming just to the relevant anatomy, epithelium, which is 5 to 7 layers thick and 50 micron thick, it's covered by non-keratinized stratified squamous epithelium. It acts as a mechanical barrier to absorption of tears, topical medications, and pathogens residing on the ocular surface. We have tight junctions, that is zonal occludence, between the walls of superficial epithelial cells. Electrical impulses arise predominantly in the epithelium and they contribute to its impermeability. Now coming to the stroma, it comprises 90% of corneal thickness. We have collagen fibers arranged in lamellae. The ground substance is made up of glycosaminoglycans, include keratin sulfate, dermatan sulfate, and chondroitin sulfate. We have keratocytes and nerves, which constitute only about 5% and 0.01% by volume. Water, however, approximately 70% by volume. What is important here, and I would like to highlight, is collagen lamellae are arranged in the direction of the diameter of the cornea. Hence, we see an increase in the thickness and not in diameter in the corneal edema. So when we have deposition of extra water in the spaces, they get deposited and the thickness increases in the anterior posterior dimension, not in the diameter. And here I would like to highlight certain important differences between the anterior stroma and posterior stroma, which become relevant while diagnosing cases of corneal edema and understanding its pathophysiology. We must understand the posterior stroma accumulates significantly more water than the anterior stroma. Why so? Because the anterior stroma, the collagen fibers are more compact, they resist swelling and water accumulation. Whereas in posterior stroma, they are more loosely arranged, allowing for greater separation. In anterior stroma, we have a higher ratio of dermatan sulfate, proteoglycans, which have lower water absorptive capacity. In posterior stroma, we have higher proportion of keratin sulfate, which is more water absorptive. Anterior stroma is therefore more rigid and it helps maintain the corneal shape. In posterior stroma, there's a natural physiologic gradient that makes it more hydrated. Further, water accumulation has a more pronounced effect posteriorly in the form of striae and Descemet's fold. So I had always wondered, why do we have folds in the Descemet's membrane, not in the epithelium in case of corneal edema? So this answers that, because water accumulates more posteriorly and throws the posterior Descemet's into folds. So more hydrated posterior stroma, however, facilitates metabolic exchange with the aqueous hemia. This is the pro side of it, and that is why probably it has been structured that way. Now coming to the endothelium, this is the monolayer of closely packed polygonal cells, approximately 5 micron thick. Its normal density varies in very young adults up to 3,500 cells per millimeter square, and in adults up to 2,000 to 2,500. These cells have no ability for mitosis after birth. However, they can change their size and shape to some extent. Endothelial, this I would again like to highlight. Endothelial cell loss due to acute trauma is compensated by adjacent cell enlargement and migration. So we have polymegathism. In normal endothelium, such cell size is always less than 30% of cells. So 30% of cells will be sized more than or less than the average. However, in chronic insult, this results in cells changing morphology. So this is pleomorphism. The previous one was polymegathism. This is pleomorphism. And 60% of, more than 60% of cells are hexagonal in normal endothelium. Maintenance of stromal detergence and transparency can occurs by two mechanisms. One is its passive barrier mechanism and one is the active pump mechanism. The passive barrier function comes through the gap junctions that bridge intercellular spaces at the apical ends of endothelial cells. So this is semi-permeable, and the permeation of water and diffusion of ions across this barrier is driven by intraocular pressure and imbibition pressure. So this is not an active function, this is a passive barrier function. And active endothelial pump, active ion transporter complexes that facilitate passive secondary flow of water. So always the flow of water is secondary to the active transport of ions. And the major component is the bicarbonate ion. So endothelial pump is dependent on oxygen, glucose, carbohydrate metabolism, and ATPase. So any factor that affects these will also affect the functioning of the active endothelial pump. Now this was all about the relevant anatomy and the physiology. So now coming to corneal hydration proper. The cornea stays in a relative state of dehydration. However, it has the highest water content amongst any connective tissue in the body that comprises about 78%. The factors that draw in water into the cornea always balance factors that prevent the inflow of water into the cornea under normal physiological conditions. So now we have the factors that will affect the corneal hydration. One is the stromal swelling pressure, the barrier function, the endothelial pump, the evaporation, and the intraocular pressure. So some of the points may sound repetitive, but they are important in understanding corneal hydration. Now coming to the all-important stromal swelling pressure. So what is stromal swelling pressure? There exists an anionic repulsion of glycosaminoglycans. They have negatively charged ions. So there will be a repulsion between the ions, causing an increase in the interfibrillary space. So we can see here. So they will repel each other. So there will be an increase in the space here. This allows for accumulation of water, and then this tissue acts like a sponge. So like the sponge swells when it absorbs water, so this swells in all directions, thus exerting an outward resistance against the IOP. Here we can see that the intraocular pressure tries to push in water into the cornea, but however the stromal glycosaminoglycans, they absorb water and they swell. So this exerts an outward pressure and a resistance to this intraocular pressure. The imbibition pressure, that is the negative pressure that causes water to be drawn into the cornea. So under normal physiological conditions, IP is equal to IOP minus SP. So any derangement in this equation will give rise to corneal edema. So we'll see different case scenarios where as the talk proceeds. So now this is again a diagrammatic representation. So IOP and imbibition pressure are the forces trying to drive water into the corneal stroma. And the swelling pressure is the force resisting water inflow into the corneal stroma. However, this is not so mathematically simple because we have an active pump mechanism there. So now coming to the barrier function, this is one of the other factors. So this is a passive function. We must understand that the gap junctions in endothelium offer less resistance as compared to the zonula occludens in the epithelium. So the epithelium offers 2 times the resistance to water inflow and 200 times resistance to higher electrolyte resistance, to electrolyte exchange. Now coming to the all-active endothelial pump, it is active. Passage of fluid out of the corneal stroma into the aqueous humor that follows the transport of the ionic transporters. So the outflow of water is always secondary to the exchange of ions. Now endothelial permeability gradually increases as central endothelial cell density reduces below 2000 cells per millimeter square. So with falling in endothelial cell density, the permeability increases. So there is increased chance of leakage into the cornea. Now, compensatory metabolic pump mechanisms can maintain the dehydrated state until a central endothelial density of about 500 to 800 cells per millimeter square is reached. So even when the cell density is falling, the active pump mechanism can still work harder and maintain it in a dehydrated state till the cell count falls below 500 to 800 cells per millimeter square. Below that, we'll have a failing pump and increased stromal hydration. Now, tear evaporation. Normal tear evaporation will make the tear hypertonic. This osmotic extraction thins the cornea by about 4 to 5%. However, this loss is readily replaced by aqueous. So the role of tear evaporation is minimal. However, it takes up a larger role in diseased corneas. Evaporation possibly plays a factor in maintaining epithelial dehydration as observed in diurnal variations in visual acuity in early stages of Fuchs endothelial dystrophy. Likewise, contact lens wearers may feel that their vision is slightly hazy in the morning when they wake up. This is because of this mechanism, because in the night time there is no lid blink, so there is no evaporation, and the cornea swells. So there is no dehydration, so the cornea swells. Now coming to the intraocular pressure, we must remember this equation. Imbibition pressure is equal to IOP minus SP. So when the IOP exceeds the stromal pressure, epithelial edema will occur. So normal stromal swelling pressure is 55 in situ. So when IOP exceeds the stromal pressure, epithelial edema will occur. High IOP and normal swelling pressure. So when the IOP is less than the stromal swelling pressure and less than 55, the stromal swelling pressure is less than 55, imbibition pressure is 0. So there will be no corneal edema. However, when the IOP becomes more than the stromal swelling pressure and IP becomes more than 0, now that negative IP becomes positive, there will be corneal edema. So we have high IOP normal SP as an acute glaucoma, normal IOP and low SP as an endothelial dystrophy. Now coming to the clinical entities of corneal edema. So when we see a patient of corneal edema, we must separate in our mind them into two categories, whether the endothelium is normal in this case or whether the endothelium is abnormal in this case. So we can divide the entities into those with normal endothelium and those with endothelial involvement. And the endothelial involvement again can be separated into few categories like primary endothelial disease, whether there is a mechanical trauma to the endothelium or whether there is any non-mechanical damage to the endothelium. So when we see a patient, we must categorize them into these subgroups. So when the endothelium is healthy, epithelial defect or acute rise in IOP, for example, acute congestive glaucoma, retained viscoelastic, they are the ones that can cause corneal edema even when the endothelium is healthy. When the endothelium is involved, that can happen in 3 case scenarios like I had mentioned before. When we have a primary endothelial disease, where we have a mechanical injury to the endothelium, where we have a non-mechanical injury to the endothelium. Now, coming to the primary endothelial disease, here we have heard that extensive talk about dystrophies. So we have the endothelial dystrophies. We can have in iridocorneal dysgenesis syndromes. Small proportion of normal population can have a low endothelial cell density, but they will not have corneal gutting. Now coming to cases where we have mechanical trauma to the endothelium, that is during cataract surgery, either due to a direct instrumental touch, due to a vitreous touch, or due to the IOL touch while IOL insertion, we can have a decimates detachment. We can have mechanical trauma during lens-based refractive surgeries, vitrectomy procedures, Brown-McLean syndrome. There can be instances of non-mechanical injury to endothelium, like in chemical injury, inflammation, hypoxia. So I'll come to case scenarios one by one. Now, what are the symptoms and signs of corneal edema? Sometimes patient may not be very symptomatic till it actually builds up. Patient can sometimes perceive a visual disturbance or a distortion or a halo, blurring and diminution of vision, light sensitivity, foreign body sensation, watering, and loss of transparency. Sometimes they see that the cornea has become white and they come to you. Now coming to the clinical diagnosis, we have to again correlate with the previous slides. In normal endothelium, for example, in acute glaucoma, when IOP exceeds the stromal pressure, here the stromal pressure is normal, but the IOP suddenly exceeds the stromal pressure, there will be a sudden gush of fluid into the epithelium. So there will be a forward flow of fluid into the epithelium because the stromal pressure is normal. Here we will see epithelial microcystic edema without too much of stromal swelling or increase in its thickness. In cases due to endothelial involvement on the reverse, the IOP being normal, the fluid will accumulate mainly in the interfibrillar space of stroma. Only when the disease process gets severe, the water finding no more space in the already full stroma makes its way into the epithelial layer. So epithelial edema will occur late. So when we see a case of corneal edema in the clinics, if we see that it is a predominantly epithelial microcystic edema, then we must think of acute conditions. If we see it is predominantly stromal or also total corneal thickness that is stromal as well as epithelial, then we must think about endothelial causes. Now this is that picture that highlights the condition. In the first case, the IOP is normal, epithelium is normal, stroma is normal, and endothelium is normal. We must think inside out. In the second case, that is acute glaucoma, here we have a normal endothelium, we have a normal stroma, but we have a high IOP that pushes the water into the epithelium. So we have epithelial edema here without too much of thickening of the cornea. Now coming to bullous keratopathy, here what happens, the endothelium is abnormal. We have lot of water accumulation in the stroma, and then once this increases, it pushes more water into the epithelial space. Here the IOP is normal. So here we have predominantly stromal edema and epithelial edema in the later cases. Now coming to a case of phthisis. Here the intraocular pressure is near zero. Here the epithelium is fully normal, but we have a stromal edema and an abnormal endothelium. So when the IOP becomes zero, there is nothing resisting the stromal swelling pressure. So what happens? The stroma swells and it swells posteriorly, like we had learned. There will be a posterior swelling of the stroma. So here we'll have stromal thickening, a normal epithelium, and the IOP is very low. So now coming to clinical case scenarios of each. Like we have a the first picture shows a post IOP spike where we have a retained viscoelastic. So this IOP spike has to be understood that this is predominantly epithelial microcystic edema and it is post-operative. So there is chance that there is some retained viscoelastic. So and this is expected to be transient and the patient has to be treated with IOP lowering agents for a shorter duration. In acute congestive glaucoma, here we can see mid-dilated pupil, AC space is shallow. And again, it's same mechanism. There's a sudden spike in IOP. The endothelium was normal. So we have a microcystic edema and the other features will guide us to the diagnosis. Now coming to primary endothelial disease. Here we can see guttae in the earlier stages when there is not too much of edema. As the edema increases and then we have bully, we may not visualize the guttae. So it's very important to see the exam in the other eye also. And in these cases, when there's not too much of edema, you do a specular of that eye or do a specular of the fellow eye. And if you remember what I had said about the endothelial count, here the coefficient of variation is very important. So that has to be less than 30. That has to be less than 30. Here you see it's more than 30. And here you see the hexagonal cells are 45% and 70% only. And of course, the cell density is very low. And here we have areas of cell dropout and lakes of fluid. So here this clinches the diagnosis. Now coming to endothelial injury, where it is mechanical. Here we see a localized area of edema. In the first picture, we see a localized area of edema with the overlying epithelial edema as well as stromal thickening. So when something is localized, we must think what lies beneath that. So in these cases, if you can see the descemet hanging or a descemet tear, apparent descemet tear, or a focal thickening over there, and sometimes you can sheen of the descemet hanging over there, then the diagnosis is pretty clear. We can do a ASOCT. If you have access to that, you do a ASOCT, and here we can see the underlying decimates detachment. So here you know what is the diagnosis, and obviously your management will change here. So unless you reoppose the decimates, no amount of steroids is going to help the case. So in this case, once that your diagnosis is clear, here you see that there is decimates detachment, there's an increased stromal thickening, and here you can see the epithelial bullae here. So everything is localized. In the areas where the DM is attached, that is normal. So here the diagnosis is pretty clear, and here the treatment will be intracameral air gas and reapposition of the decimates. And in very severe late cases, you may need an endothelial transplant. Now coming to endothelial, other kinds of endothelial injury, like post-phacoemulsification, you can see stria, you can see striate keratopathy. This is a very mild form. Sometimes you can see them very extensive. There are some other cases of decimates membrane rupture, like in acute hydrops or post-trauma decimates tear. So these are some of the other instances where there's a mechanical give of the decimates. Now coming to some of the inflammatory causes, like HSV keratouveitis. This is in fact is the same case with acute congestive. She had come with uveitis and she has been dilated with atropine. Then she went into acute congestive. Here, if you can see, you see posterior synechiae, you see a lot of cells there, and you see some fine capies here. So this clinically, this looks like HSV keratouveitis with a raised IOP and a combined mechanism glaucoma. Raised IOP, as well as she went, the patient unfortunately went into acute congestive attack also. Now this is the HSV disciform keratitis. Here again you see it is localized, and the edema overlies the area of decimates involvement and endothelial involvement. Here you will see few capies below that, and the edema is restricted to that area of involvement. So this is how you categorize these patients, mentally compartmentalize these patients and look into those areas, and then think likewise. All edemas are not due to same cause. Now, this again is a post-operative inflammation. Now, we have to think whether it is due to retained viscoelastic or why does the patient have so much of edema. So here, if you dilate the patient, you can see a little bit of retained cortex there. So that probably is giving rise to the inflammation, and this is a inflammatory glaucoma. So in this case, if the cortex doesn't resolve, then you have to go to mechanical removal of the cortex. So that would address the edema. So now Brown-McLean syndrome, here the etiology is not very clear. Sometimes in this we see only peripheral whitening, peripheral corneal edema. Central cornea remains fairly clear till very late. And the etiology is not very clear in these cases. Sometimes they're associated with fuchs, and sometimes they can be seen in post-operative cases, especially opaque cases. Sometimes they can be seen even without surgery. So wherever you see a case of circumferential edema and the central remaining clear, think of Brown-McLean syndrome. Here the treatment would be steroids and hyperosmotic agents. Now coming to TAS. This is again a post-operative inflammation, and it is a non-mechanical damage. So here we have a sterile post-operative anterior segment inflammation that occurs early. Sometimes we can have a delayed TAS too. And the patient usually does not have too much of pain because And what clinches the diagnosis is the limbus to limbus corneal edema. Here you will see a limbus to limbus corneal edema. And in the inflammatory kind of TAS, you can see a fibrinous AC reaction. And absence of vitritis is very important because any evidence of vitritis will be more in favor of endophthalmitis. So some common agents that are attributed to causing TAS are antiseptic solutions used for pre-surgical prep, topical and intracameral anesthetics, irrigating solutions, intraocular medications and preservatives, viscoelastics, and detergent residues on the ophthalmic surgical instrument. Now, chemical carbide injury. So this is again non-mechanical injury. Here it is multimodal. We have loss of epithelium, so we can have epithelial edema. In deeper penetrance, there can be inflammation and endothelial damage. So this is multimodal, and the treatment here would be mainstay would be steroids, and of course amniotic membrane graft in the earlier stage. Now, we must also look at the other associated findings. Like we saw a little bit of cortex there, we must examine the eye very clearly because sometimes the associated findings will lead us to the diagnosis. Like the shape of the pupil, whether it's peaked. If it is peaked, then maybe there's a weaker vitreous there, or maybe the haptic has come into the anterior chamber there. So we must see the pupillary size and shape, and whether it's dilated, fixed, that is more in favor of a toxic condition. And mid-dilated fixed pupil with shallow AC is will tell us that it's an acute congestive attack. And we must see the contents of the anterior chamber also. KP is hypopia and hyphema, vitreous retained lens fragment cortex or epinucleus. All that will tell us why there is corneal edema. Now coming to the diagnostic investigation. Once that you have a clinical picture in mind and you want to follow it up further, we go into the diagnostic investigation. So this is to document and to clinch the diagnosis and for medico-legal purpose also. So we do a pachymetry, ultrasound pachymetry, Visante OCT, Cyrus OCT, and pentacam tomography. All devices gave a reliable pachymetry below 650 micron. However, above 650 microns, all were comparable except pentacam, which overestimated the amount of overestimated the pachy. So, and pentacam and US pachy should not be used in very severe corneal edema and opacity. Now, specular microscopy may not always be possible in very severe corneal edema. Preoperative specular microscopy is therefore mandated. However, in cases that have come to you for the first time, if you can't do specular in that, do a specular in the fellow eye for comparison, just to know whether it's a primary endothelial pathology or it is a normal endothelium and it's just a post-operative injury that has caused endothelial cell loss. Then cell count and morphology, both are very important. Anterior segment OCT where possible, useful adjunct, particularly when clinical examination is limited. Here we can see things like Descemet's detachment, angle crowding, ICL inversion, and other structural abnormalities. It is both for diagnostic as well as for follow-up purpose. Management is medical and surgical. Medical, we have hypertonic saline, which is again temporary, that keeps the cornea dehydrated for a short time. Bandage contact lenses, again, that are just for symptomatic relief. IOP lowering agents need to be given where the IOP is very high, and sometimes they may be added to increase to counter steroid-induced IOP spikes, because some of these patients need to be put on steroids for a long time and in larger dose. Lubricating eye drops and gels, again for comfort. Steroid, where the etiology is inflammation, that it can be topical as well as systemic, especially in cases like TAS. The Rho kinase inhibitors, which have assumed importance in recent times. So I've given special space to Rho kinase inhibitors. So Rho A protein enhances cellular adhesion and proliferation. Rho kinase has a regulatory effect on this Rho A. So Rho kinase inhibitors will inhibit this Rho kinase in the endothelium, which will help cell migration and adhesion. However, a word of caution, when we use ripasudil and netarsudil, we may get pseudogate. So we need to follow up these patients. These pseudogate are usually reversible. They usually reverse automatically after a period of use. However, we need to follow them up and discontinue if they persist. So this is the mechanism of action of Rho kinase. So ultimately, endpoint is they prevent loss of adhesion and they prevent apoptosis. So they prevent cell apoptosis. Now coming to the surgical management, it depends on the diagnosis. So before we go into surgery or the medical management, we must be very sure what is the diagnosis. For example, in a Descemet's detachment, there is no point just increasing steroids. We have to reoppose the Descemet's. And similarly, in a case of stride keratopathy, we cannot blindly go in and inject air because that is not going to help. So anterior stromal puncture in non-seeing blind eyes or patients who cannot maintain a graft. The goal here is pain alleviation and symptomatic relief. We may go for sectoral anterostromal puncture or a sectoral PTK wherever it is only a very small sector involvement and the patient is troubled by the cyst and the bully there. And Descemet's detachments need surgical reapposition if they're vision threatening. If they're very small and very peripheral, we just leave them and follow them up. But if they're central and large and vision threatening, they need to be reopposed as soon as possible. Endothelial keratoplasty, where primary pathology is in the endothelium, and full thickness penetrating keratoplasty may be needed if associated with extensive surface scarring, pus, and shallow chambers. extensive iris tissue loss and aphakia. So sometimes in Descemet's membrane give way like acute hydrops, just a descemetopexy, like with using compression sutures, intracameral air will suffice. Here you can see that the break was identified, and then post compression sutures, there is apposition, though we see the tightening effect of the sutures, but the Descemet's break has reattached and there is no edema. Now, endothelial keratoplasty, where there is primary endothelial pathology, and penetrating keratoplasty, where endothelial keratoplasty cannot be done. So my references are these. So I would like to end by my talk by this quote, which I truly believe in: the eyes do not see what the mind does not know. So before we jump into the diagnosis and the management, we must be very clear in our mind. We must categorize what we see into some compartment and then follow it up. So we cannot underemphasize the power of observation. Thank you.
Thank you so much, Dr. Devi Aishwarya ma'am, for discussing elaborately the basic anatomy, the pathogenesis, the management, and the various scenarios in detail. The topic is now open for discussion with the expert panelists. Can we please have Dr. Manisha Acharya ma'am for her input? Dr. Manisha ma'am, can we please have input from your end? Okay. Can we please have input from Dr. Nikhil Gokhale, sir?
Yeah, I think nice talk and comprehensively covered, and she's shown nice pictures as well. That's what I would say.
Thank you.
Yeah.
Thank you so much, sir. Dr. Josephine Christie, ma'am, can we please have your valuable input?
I think the topic was excellently covered. I don't have anything to add. Thank you, Dr. Nandita, and this was a wonderful session. Thank you for inviting me.
Thank you so much. This brings us to the end of today's
I
session.
had a question if the panel can address it. So
Yes.
like, do you really treat the endothelial dystrophies with rho kinase inhibitors, and how long do you treat them for without any surgical intervention? I mean, like, do you keep them as a stay of as part of your treatment regimen routinely?
I think if I can just say in the beginning is that very often in our clinics, we find patients who have been diagnosed as Fuchs dystrophy, or they have just been diagnosed with endothelial, guttata, and they are put on rho kinase inhibitors. So I think probably that's overdoing as far as I can understand, because there is no end point to that treatment. So somebody might, how long are you going to use? What are you going to monitor? Especially because, so they would be useful if you're doing something like a Descemet stripping in the center or something like that. Just giving a rho kinase inhibitor for anyone who has endothelial dystrophy may possibly not be the right thing, because I'm just saying this because I see these type of patients in our clinic very often. Somebody is giving them. I think so we still somehow, I think also there is a discrepancy in the response to rho kinase inhibitors that we see in our country here and what has been reported elsewhere in Japan and other countries. Maybe there is something different in the preparation or the formulation. I really can't say. Some of the places where I empirically would use it is, somebody sends a patient who has post-cataract corneal edema, which is patchy, localized. So we just tell them, in the benefit of interest or the doubt, whatever you may call it, some patients we do use these type of rho kinase inhibitors. Many of them may be recovering on their own, or the drops are helping, is difficult to figure out really, because we can't really, in a small set of patients, difficult to say, but that is one place where we tend to use. And of course, in situations where there is a glaucoma plus a endothelial problem, or for example, some of our post-graft patients, maybe, one could try to use them. I've had some patients with post-keratoplasty where the endothelium was, the graft was looking to have some microcystic edema in the periphery, and after starting these, somehow the graft has retained clarity or come back to clarity. So I'm not really sure what are the, like whether we should use them as often as we are. Uh, and there are limited patients who will really benefit from, these drops. I'm sure Dr. Christie and Dr. Manisha, if they're there, they can add some more points, or you can share your experience as well.
Same here, sir. I have again used it for patients for post-cataract corneal edema just when I want to wait for some time, no, until 3 or 4 months. I just tell them, like, anyways giving you some medications. But as you told, like, we never know whether it was actually due to the medication or it was their own resolution. So I use it Tripasudil 4 times a day. So that is a normal dosing that I do, because that's what I've heard people tell that it works. Otherwise, it doesn't have much effect. But even then, I have no direct evidence on any single patient who has actually improved other than postcorneal edema or any endothelial dystrophy which improved with Tripasudil alone, or any improvement that I've seen.
The other thing, I don't know, maybe Manisha, you're here as well. If you tell us that some of the patients who have bullous keratopathy, if you give them Ripasudil, their epithelial edema from those large painful blisters start looking like, this typical cobweb-like edema that is described with Ripasudil. And some of these patients don't seem to have the sort of pain which they had initially. I don't know whether it is anecdotal in or whatever, but some patients with this type of edema don't have that typical blistering pain which they would get with the large bullae rupturing. So I don't know whether the edema that we get with the Rho kinase inhibitors is why it is not painful, or how is it different. I don't know. The pattern of edema changes once you give these in some patients. I don't know whether that.
So when, I mean, there have been one patient I still remember, I thought it was more like what is described, that it's the toxicity or the side effect of Ripasudil, but definitely the patient was not very symptomatic. And I mean, we had as it is planned that the patient will require a DMEC or a DSEC depending on that. But yes, what you're saying, it makes I mean, there's one patient I can relate to what you're saying. I have not thought about it. Maybe from now onwards, I'll start thinking the pain level of that. And but in that patient, the only thing, this was one patient, but there have been a couple of patients where with Ripasudil, the postponement of surgery has happened. There was one-eyed patient which I was dealing with. I just didn't feel like doing anything because he was 6'18", a fake ache with edema. But I think with the Ripasudil, I can now see that the patient was saying, I'm feeling better. I can see a little better. My daily activities have improved. So, I mean, definitely I would prefer to use it as an agent where it's going to postpone when I'm going to do that transplant. But very well described, Dr. Das.
Thank you so much.
Thank you so much, ma'am. So this brings us to the end of today's session. A very big thank you to our speakers, Dr. Vanati ma'am, Dr. Bhavna ma'am, Dr. Veena ma'am, and Devi Aishwarya ma'am for such informative and detailed discussion on each topic. I'm sure the students who are watching this session must have gained a lot more knowledge by the end of today's session. And to our expert panelists, Dr. Manisha Acharya ma'am, Dr. Nikhil Gokhale sir, Dr. Josephine Christine ma'am for your valuable input, to AIOS, Dr. Partha Biswas sir, Dr. Santosh Hunawar sir, Dr. Manoj Chandra Mathur sir for organizing the extensive sessions of Guru Sangam. Thank you so much everyone for taking out time on Sunday morning to be here for the session. And we have our next session of Gurugram, session 6 on cornea today evening from 6 to 9 p.m. With this, we would take leave from this session. Thank you so much everyone for joining in.
Thank you. Thank you so much.
Thank you so much, sir. Thank you so much, ma'am. So we can end the session. The support team, can you go offline, please? Do we have Mr. Sunil ji from the support team? Okay. Thank you so much, everyone.